So I was asked to talk about strategy for difficult left atrial appendage therapy. I'm going to focus the talk mostly on currently FDA-approved device, which would include the WATCHMAN device. Just as a quick review, I know most people in the room already are well familiar with the procedure. It involves a transseptal puncture, imaging of the left atrial appendage, followed by insertion of a device, and then once you're satisfied and happy, you release the device. It seems very quick and easy, but it turns out that depending on the anatomy of your appendage, your procedure can be either very quick or it can be very long, and you can be very satisfied or very dissatisfied. So it's really all about your imaging and your planning and so forth. So I was asked to give strategies for achieving success in this case. So I have 3 top procedural limitations that you would want to focus on in these difficult cases. The first is the transseptal puncture. The second are the cases where you don't have enough depth to deliver your device. And then the third is your inability to get coaxial when delivering the system. So just to start off with the transseptal puncture, this shows the anatomy and the preferred transseptal crossing location for patients for a left atrial appendage procedure. The red star denotes the inferior posterior, which is sort of the classic teaching for where you should go ahead and cross, which is very different than some other transseptal procedures that we do, such as MitraClip, for example. But there are some anatomic features of your septum, as well as of your patient generally, which can be difficult and can cause you some serious problems. A small fossa or lipomatous hypertrophy can limit your range in terms of picking the optimal location, and you may find that your transseptal guide is being forced into a certain corner that you don't really want to be. Similarly, a thick and fibrous septum can be very difficult to cross, so there are some strategies to get through there. And then a tortuous IVC, as Molly's case in the last session, can definitely be a real pain in terms of getting across. So I recommend, we typically use the Brockenbrough device, the Brockenbrough needle for our transseptals, but I really recommend having an alternative strategy, as Molly highlighted in the last session. Some people might use the back end of a wire, hook it up to a bovie, and try to get through if you have a thick septum. We use the Baylis as our go-to. We use radio frequency. And I find it particularly helpful for 2 instances. So the middle panel is the fibrous septum, where you might find that you're putting a lot more lean into your transseptal than you really feel comfortable doing. And then the second is the aneurysmal or the stretchy septum, where you find that you're tenting all the way across the left atrium and you're almost touching the lateral wall, and you kind of like close your eyes as you make that puncture, and then you pull back immediately, hoping you don't go through the wall. So I find that the Baylis to be very helpful in those 2 instances. And I recommend having a backup strategy when you are doing your transseptal punctures. Tortuous anatomy, this is like the extreme example right here. But you can notice on the left screen, we use a telescoping guide technique. So I'll take a 14 by 45 centimeter sheath or longer from the right femoral vein. If I find things are tortuous, we'll go ahead and telescope the transseptal guide inside of that sheath. That does 2 things. It'll straighten out your IVC, and it'll also reduce the friction at the bend points. And I find with a big curve on your transseptal needle, you can generally reach where you need to go. Another thing you can do is you can put a buddy wire up, get another access, or put it just side by side, put a Lenderquist up the IVC. That'll straighten things out as well. In this particular case, you see we use the Baylis. Notice right now the Baylis needle in this picture on the right is basically just crossing the septum. So this is to show you how tortuous things are. We're very leftward on the patient. The spine is all the way to the left of the image. We also found that in this particular case, the septum was quite thick. So not only do we have trouble getting our crossing location, then just getting the dilator through the septum was quite a challenge. So we ended up putting in a stiff wire, advancing a 10 millimeter balloon. And you can see we're up at pretty reasonable pressures here, still with the resistant waist. Finally, we were able to get that to give. Switching gears to cases where there's not enough depth for the delivery. This is an example of a very wide but short appendage. These cases can be done. Similarly, with very prominent pectinate, this really gets in the way of the feet opening up during your delivery of your device. And then the multiple small lobes can also be a real challenge when trying to deliver. But the rules are changing in terms of what is acceptable anatomy and what is not. The classic teaching when I first learned to do the procedure was that you needed the same depth that you had in terms of if your diameter is 30 millimeters at the ostium, you needed 30 millimeters of depth to deliver. And that's really not true anymore. We're finding that a lot of these appendages which have inadequate depth can successfully be treated. Of course, you don't want to advance your sheath, right? The classic teaching is you're always advancing over a pigtail, and you're never advancing your device itself because this is a very pointy tip when the device is exposed. But the truth is, once you let the device open and warm up and flower, it's a lot more gentle, and you can safely advance with caution in that case to try to gain a couple extra millimeters of depth as the device is shortening and opening up. And then, of course, a look to the future with the WATCHMAN Flex. It's a shorter device. We're going to be able to get away with much smaller depths to be able to deliver this device. And then, of course, the leading edge is curved and a lot more gentle. Of course, this is not FDA approved and not currently available for commercial use. And then the last issue is the inability to get co-axial. And this is affected by several characteristics. Your septal crossing location is probably the most important in getting coaxial delivery. The delivery cable can cause wire bias. You can have a prominent Coumadin ridge and complex left atrial anatomy. The notorious one is the anterior chicken wing. So, you never want to get a big shoulder if you can avoid it. You'd love for your device to sit totally coaxial whenever possible. There are 3 different pre-shaped curves that are available. We use the double curve probably 80 or 90% of the time. I almost never use the single curve, but I do use it occasionally if there's a posterior chicken wing or a posterior windsock. And then the anterior curve is particularly helpful, I find, in cases where certain initial maneuvers don't allow you to get coaxial for an anterior chicken wing. This is an example of switching guides. So the image here shows you an anterior chicken wing with the ostial plane. And we started off with a double curve sheath. So you notice we're very horizontal, very not coaxial at all. And then we switched out to an anterior curve, and this just shows we are a lot more coaxial. I wouldn't say this is perfect. We were able to use this and get a good result. But of course, if this doesn't work, there are other strategies you can use too. So if you want to repeat your transseptal location, you can go, in this case, you would go a centimeter or so inferior and probably a little bit anterior, and then go ahead and cross, and then you'll notice that there's a completely different orientation. So the middle pane is using your first transseptal location, and the pane all the way on the right makes you almost completely coaxial. So anatomic variability is a limiting factor for appendage therapy. A stepwise approach to anatomic limitations results in improved success, and ongoing device improvements, I think, are going to simplify this procedure for the future. Thank you.